Welcome everyone to our July AABIP webinar on behalf of the moderators, Drs. Majid Shafiq, Ara Christian, and myself. So before formal introductions, just a few housekeeping matters. So everyone, please note that this webinar will be recorded. It, along with previous and future webinars, can be viewed on the AABIP website and can be found under the Education tab, as we can see on this slide on the front page. Next, a couple of important disclaimers. The AABIP does not endorse any specific technologies or products. Also, the content and views expressed within the webinar represent the opinions of the speaker and do not necessarily reflect those of the AABIP. During the webinar, please note that the audience will be muted, so you will not be able to verbally interact with the speaker or audience. However, you can certainly ask questions. To ask questions or communicate with the group during the webinar, please type them into the chat box. This can be accessed by clicking the chat icon located in the toolbar at the bottom of your screen, as we can see on this slide as well. Please make sure your chat is set to direct to all panelists and attendees so that we, along with the entire audience, may see the questions. We will keep track of the questions as they come and address them towards the end of the session in the formal Q&A period. So please type in your questions at any time during the talk. So now that we got all of that out of the way, I'd like to take this time to introduce our topic and panelists for this evening. We have an excellent panel who is knowledgeable and who have worked really hard behind the scenes to put this information together on this very important topic that most of us have a lot of questions about. And that is the current status and future directions of IP board certification, recertification, and practice pathway. So we're gonna start off by introducing Dr. Murgu, our current AABIP president, who really doesn't need any further introduction. Followed by Dr. Tanu. She's the chair of Pulmonary Medicine Board of ABIM, and also professor of medicine, vice chair for clinical affairs, internal medicine, lung cancer screening program at Yale. Followed by Dr. Pestis, our chair of certification committee, and also Dr. Dibian, who is our chair of board eligibility application review committee on ABIP and assistant professor at Henry Ford Hospital. We're very excited to have each and every one of you here today to share all the information on this important topic. And I'll now hand it over to Dr. Murgu to start.
Okay, thank you. Thanks for putting this together. I understand that there is a need to clarify questions, concepts, and really our overall philosophy of certification and recertification. And my role today, which screen are you seeing? With notes or the full screen?
We're looking at the correct.
We're good.
Full screen.
You're good. All right, so my role tonight as part of the executive committee and the board of directors for ABIP, and as the president of the association for one more year, is really to mention the vision, the mission, and our values as they are pertinent to the certification process. And today, to be clear, we will offer our perspectives as they stand today to bring clarity to the process. And there are questions that we may not be able to answer. So it's really meant to be for clarity, not for certainty. And I also want to thank the leadership of the ABIP. These are the 13 people in the board of directors elected in a very transparent and democratic way by the ABIP members. They do represent the ABIP, and they're really responsible and accountable for the affairs of this association. So decisions pertinent to certification and recertification are board decisions as outlined in the bylaws. So to better understand why we're doing certification and maintenance of certification certification or recertification, I want to briefly mention what our mission is. So that's the purpose of the organization, right? And we believe we're here to make a positive change in the care of patients suffering from thoracic disorders. And at the ABIP level, we do that through innovative technologies, through minimally invasive procedures, and through what we believe is transformative education. The vision is really the roadmap that guides our strategic planning beyond the purpose of this webinar. And then the values are our guiding principles that empower us to pursue that mission to achieve the vision. And in regards to some of the core values that we have at the ABIP, we believe that we're sincerely invested in the growth and support of our members, and that's community. That we really foster change for our patients and for our members. That's advocacy. Increasingly, due to efforts of our peers, we are intentional in our efforts to amplify the diverse opinions of our members. And in fact, a side note here, the clinical practice pathway is really a proof of our inclusive actions. And then ultimately, we strive to do more and to be great. And that's with a perspective on constant improvement, which can only, that's excellence, and that can only be achieved through education and assessment. So to make a positive change, right, that's the mission. Just like an individual, you need to be credible and you need to show empathy. Organizations are no different. We need credibility and empathy. Credibility, just like for individuals, is a two-step process. First, we need to achieve competency, and then we need recognition for that competency. Only one criteria will not suffice. So competency will gain the trust of our patients, of the public. And internally, now we do that through the IP fellowships, that's the education, and the IP board examination, that's the assessment. But that's self-regulated. We're doing it on our own at the ABIP. So what about the recognition by our peers, recognition by the public, recognition by outside bodies? For the IP fellowships, we're doing that with the ACGME. And then it is our intent, if ABIM is willing to accept our application in the near future, to transition the IP board examination to that third party. And then we need empathy. I recently talked to the IP fellows at the boot camp, and I mentioned there are different types of empathy. There's just like cholesterol, there is a good and a bad type, and there are books written about empathy. But from organizational standpoint, we believe in the empathy of doing, and we believe that having an outside body that's regulating the board certification and recertification, it is actually a proof of empathy, as I'll highlight a little later. Dr. Tanu here, one of our guest speakers tonight, will elaborate on why we certify and recertify in this country. There is plenty of evidence. There is plenty of evidence. I will only point out two things. There's evidence that knowledge, cognitive, and skills declines over time. And there is evidence that the public wants the professional bodies to conduct periodic reevaluation. I will let Dr. Tanu later to elaborate on this. But ultimately, it's the patients that are our primary constituency, and we are responsible to them. We're accountable in front of the public and to our patients, and we need their trust, which again, that comes with competency and with recognition. And just a side note, a board examination is not even a proof of excellence. It's a proof of minimum competency, and the ABIP itself does not force anyone to sit for the board. It is a voluntary endeavor. So then questions came out through the registration process and through the chat rooms. I understand there are all kinds of chat rooms online. And these are some of the questions that I will try to answer tonight. Why transition to ABIM? What will ABIM offer differently? Does it cost money? So here is our stand. ABIM has a long-standing expertise in assessment. They've done it for many years. They've done it for a variety of fields, for our peers in other specialties. And that's what they do. They are experts in assessment. If you check their website, they have clear blueprints, they have a rigorous methodology, and they have the resources, which, by the way, at the ABIP, as we continue to grow and diversify our portfolio of activities, we're increasingly limited in our bandwidth to provide resources for board certification and recertification. We count a lot on our ABIP volunteers for question development. We use testing organizations to validate questions and to implement the exam. But really, we rely a lot on our volunteers' resources, which are very limited. And then ABIM is an outside body. It will offer that impartiality that brings credibility because we're not self-regulating. And so credibility in front of public, in front of our patients, other organizations. And to me, it's also, again, back to empathy. That's a personal opinion. By not testing our own peers, the passing rate is 90%, but the 10% that fail, they are failed by their own organization. So passing that responsibility to an outside body, I personally think it's a proof of empathy. And then very importantly, ABIM offers flexibility in the assessment methods, which we are not. And I'll come back to that in a second. There was a question about asking the members, what they think and what they prefer. I do want to remind people that a year ago, we performed a 30-question survey that was sent to our membership with a response rate that I thought was fantastic, 226. At that time was about a third or so of our membership. And if you look at the demographics, that was representative of our members. So this is what we learned. And I only emphasize on two of these questions from the survey. First, our members want an assessment that's also instructive. They want to learn from the process. More than 80% answer that. And right now, the way we give feedback for our board examination with the way we're doing it, which is the way we afford it, we're not doing that. We're not providing feedback. We're providing some guidelines in regards to the domains where people may not have performed the best, but it's not what ABIM is doing right now, especially with the LKA. And then we also learned that people have different styles and different preferences in regards to testing. And there is a wide distribution of responses here, with 35% of people preferring a 10-year examination, which is the only method of assessment that we can afford at this time. We looked extensively within certification committee. We spoke with our testing company Measure. With the resources that the ABIP has right now, we cannot afford a different testing methodology. So my last slide is this, yes, I think it's a truism that doing a certification and recertification will take time, will cost money, it requires effort. It is for a greater good if you really think about it. And it does cost money because we do have to validate those questions. We do have to implement the exam. Even though the questions are written by our volunteer members, the implementation of the examination is expensive. So for us, the transition to ABIM, if ABIM is willing to take us, is not just a credibility matter, it's really an operational endeavor for us. There is a reason interventional cardiology has done that, our peers from sleep medicine. So I leave you with this question, are we the organization that we want to be right now? We're doing lots of things, but maybe moving forward, we should just focus on education, on advocacy, and on research, and leave the high stakes examination to an outside body with a broad experience and expertise in assessments. Again, it's a matter of credibility, empathy, and sustainability. There will be more talks about this at the annual meeting. If you haven't registered yet, please do so and join us in Chicago at the end of August. Thank you for having me. I will stop sharing right now. All right, and I'm gonna pass the mic to Dr. Tanu.
Okay, can everybody see my screen?
Yes, that's
Yes.
same.
Okay, great. Thanks for inviting me to participate in this webinar. I completely appreciate the effort that AABIP is putting into all of this. And I'm going to give you a kind of high-level view of certification and recertification. By way of introduction, I'm Lynn Tenoy. I'm on faculty in pulmonary critical care and sleep at Yale. My focus is actually thoracic oncology. And so I interact very much with our IP people, and I actually was the force behind starting that program. So just know I'm on your side. I'm the chair of the ABIM Pulmonary Diseases Board, and I'm the past chair of the exam committee. So if you want to understand why we certify and recertify, you actually have to go back to the 1800s in the US. And in the late 1800s, American medicine was like the Wild West. Anybody could practice, and practice was incredibly variable. And medical education was not standardized at all. And the public recognized this, that American medicine was bad, and bad particularly in comparison with what you could receive in Europe. And that triggered the Carnegie Association, the Carnegie Foundation, to commission what became known as the Flexner Report, which was published in 19 and was a damnation of American medical education. And really, it pointed out how poor it was, how variable it was, that the curricula were inadequate, the students were poorly prepared to enter medical school, and graduated not competent. And this created an effort to completely overhaul our medical education system to the level of rigor, standardization, and high quality it is today. And also in the 1800s, there was all this scientific movement going on in Europe with development of actually surgical techniques. And in 1889, Hopkins established the first residency training program in Baltimore. And it was really prompted by technical advances in surgery. And that residency training became the model for United States specialty training after medical school, and has been really adopted around the world. And so now we've created a body of people who have specialty training, have been receiving really rigorous medical education. And the various societies realized that they had to set standards for who could practice the specialty. So all of this evolved out of physician feelings of need for standardization so that people were competent, that people were known to be competent to practice. And this was, the first one was the American Board of Ophthalmology in 1917, followed by otolaryngology in 1924, and then multiple other boards, of which there are now 24, with ABIM becoming a board in 1936. And in the meanwhile, there are all these subspecialties now also creating training programs. And pulmonary diseases was one of the early ones. And in 1941, with cardiovascular and GI, developed its own sub-board at ABIM. And it's important to recognize that each of these groups sets its own standards for competence. They're determined by people within the specialty. And really, as a result of all of this reform in education, graduate training, and then certification, the end result is the medical profession in the US is very highly respected and highly trusted at home as well as abroad. So that fundamentally, board certification is a standardized objective validation of competence, but it's used for different reasons. And in particular, it's used as a proxy for quality. So physician practices use boards as a criterion for hire. Hospitals often require this for medical staff privileges. Insurance companies may want it if you want to participate in a panel. And the public uses it as an independent validation of physician competence. And if you go to the ABIM website, on the front page, anybody can check a physician's certification status. So we accept that there should be competency evaluation when we're training. In medical school and in residency, that's LCME and ACGME. And then we accept that we should be tested at the end of training with the board certification examination. But competency evaluation over the career of a physician really only came into the light, with the light shined on it in the past 20 years. And really, I think the question we have to ask is, if you don't recertify, how do we know that we're competent? Who is watching us? Is it our hospitals, our state licensing boards, our peers? ourselves. And I would point out that we are unique in that we enjoy the privilege of self-regulation of our ability to practice. And that is different than every other profession that holds the public safety in their hands. And reviewing this, I think the group that's most analogous to us are commercial airline pilots. You know, you get in an airplane and you assume that you're going to be safe and you're going to land at the other end. They are regulated, as are air traffic controllers, by the Federal Aviation Authority. And when you want to become a commercial airline pilot, you have to study, you have to sit for the exam, you get a license. And once you are licensed to fly, you have to do annual maintenance of certification. And commercial airline pilots have live examinations with an examiner of their ability to operate the aircraft. They have simulation testing, which is live, to that they can respond in an emergency. They are tested specifically on their proficiency with the aircraft that they are licensed to fly. And they have to undergo a very rigorous medical examination once a year. That's about 60 to 80 hours of live testing every year if you want to retain your ability to fly a commercial plane. FAA is similar. They actually get tested monthly. And really, in contrast, we aren't regulated by external agencies. We're not regulated by the boards either. Once you have your MD or equivalent degree and you get a state license, you can practice. We also have no mandatory retirement age because, again, we're not regulated by anybody. The airline pilots had to fight in Congress to get their mandatory age raised to 65. We actually have no ceiling on how long we can practice. And so let's, consider those other places that you can have your competence assessed. We all have hospital or institutional re-credentialing, which is quite subjective. Your chair or chief has to attest that you can provide care. We typically don't do formal case review in internal medicine, and proctoring is typically only done when you want to practice a new procedural skill or if your competence has been questioned. State licensure requires that you pay a fee. There's no exam. Most states, but not all, require CME of variable amounts, but as far as I know, only West Virginia stipulates that the CME has to be in the field of practice. And then we don't do peer review after graduation from the terminal training. We did, as students and trainees, get structured feedback often with benchmarks of competence, but we don't formally externally assess each other this way once you have finished your last training. And so there was a survey done by the AMA of, looking, what do we do with incompetent physicians? So 1,600 physicians across many disciplines were interviewed. Most of them had had an encounter where they felt that one of their colleagues was incompetent or impaired. And 96% agreed that those physicians should be reported. However, even though most people had had the experience, 45% reported that they did not report. And I think many of us had had that experience where we are watching a colleague and we're a little uncomfortable with their competence, but it's very uncomfortable and hard to report that person. So if it comes down to, I need to assess myself, how good are we at that? And there's very little literature on this because I think it is an uncomfortable topic. There is this one systematic review of the literature. They found 17 studies that looked at physician self-rated assessment compared to external quantifiable measures like structured exams, standardized patients, simulation, chart audit, and so forth. And the conclusion of this review was that there were weak or no associations between physician self-rated assessment and external objective assessment. Concerningly, those who performed least well on those objective assessments also self-assessed very poorly. And so I think we have to accept that confidence in ability does not correlate with competence. And there is this one big systematic review looking at, well, as I get older and I'm more experienced, do I get better? And the answer, unfortunately, is no, it doesn't seem that that is the case. In the 62 studies that they reviewed, and the data are shown here in this red box, 3/4 of the studies reported that performance actually decreased with increasing years in practice for outcomes like knowledge, diagnosis, and screening therapy and outcome. And only 2 studies reported the opposite finding. And so I think in terms of assessment, we need an outside body to do that because we're not very good at doing it ourselves. And so what about the flip side? If I'm board certified, does that mean I'm a better doctor? Do I give better care? And this too does not have a lot of literature, but there is a growing body of literature because I think of the debate as to whether recertification is legitimate. And so there was a really big study done by the RAND Corporation in conjunction with the University of Pittsburgh. They looked at claims data for over 1 million patients in Massachusetts who were taken care of by 13,000 physicians in commercial health plans. They looked at physician individual characteristics and then compared 124 quality indicators for 22 conditions across many disciplines. And in all of the variables they looked at, the physician characteristics that were associated in their multivariate analysis with better care were female sex, sorry guys, US training, and board certification. And in a sort of a parallel study that was done in Canada, asking the same thing about quality of practice, they looked at 500 family practitioners, and in that study, the same sort of factors fell out, including certification by the Canadian board and actually live peer assessment or testing in person. And there, again, are now many studies demonstrating that board certification is associated with better outcomes. Again, causality is like impossible to prove, but there is definitely an association. And I'm not going to go through any of these except the first one. And this is Fiorilli and colleagues published in Circulation. And I pulled this one because this is from interventional cardiology, which I think has many parallels to the interventional pulmonary community. So there's this thing called the CAF PCI registry that collects data about PCIs done in the country. And they took data from the year 2010. There were over 500,000 PCIs performed by about 5,000 interventional cardiologists, of whom 2/3 were certified by the Interventional Cardiology Board, which had come into being in 1999 or 1997, I think, and 1/3 were not certified. And there were only 2 outcomes in their multivariate analysis that were significantly different between these 2 groups. Those happened to be in-hospital death and emergency cabbage because of a failed PCI. So these were not like minor things. These were probably the 2 most important outcome measures that exist. And the bottom line is when you use the ICARD certified group as reference, the odds ratio for in-hospital death, if your PCI was done by a non-certified cardiologist, was 1.10, meaning that there was a 10% higher likelihood that you would die during that hospitalization that the PCI occurred during. And the odds ratio for having emergency cabbage if your cardiologists were not ICARD certified was actually 1.32. So 32% higher likelihood that the PCI failed and resulted in this emergent surgery. Those are big numbers. And again, is it causal? Well, there is definitely this strong association. And I think for your group, this is an important thing to consider. And so I think we can agree that no single factor is a sufficient predictor of quality of care. But I think board certification, including maintenance of certification, is a biomarker of physician quality. It demonstrates a commitment to keeping up to date, an acknowledgement that self-assessment is unreliable and that an external assessment can be valuable. It is an opportunity to receive feedback on strengths and weaknesses, and it implies our willingness to act on feedback. And I want to just come back to a point Tim made in his talk, and that's about the trust in our profession. So Gallup polls people every year, and one of the questions they ask is, tell me how you would rate the honesty and ethical standards of people in these different fields. Very high, high, average, low, or very low. And doctors and nurses are at the top. So the public trusts us. It's not perfect and it's fragile, but thankfully they trust us a lot more than lawyers, members of Congress, and car salespeople. And I think this is really important because this trust means that we still can regulate ourselves because the public trusts that we will do so. And so in closing, my opinion is that we enjoy the high respect of our communities. We have been granted this very unique societal privilege to self-regulate, and that is grounded in physician-driven standardization of education, training, and assessment of competency. And the public trusts that we will uphold our standards. But we have to be honest that we're not good at self-assessment. And so external objective evaluation to assess whether we are keeping up in our fields of practice, I think, is of very high value in maintaining our trust in each other and the public's trust in us. And I'm going to close there, and I'm happy to take questions at the end. I think I'm going to pass this to Nick and Labib.
Thank you, Dr. Tanu, and thank you, Dr. Morgu. I'm going to be sharing my slides. So hello, everyone. Thank you for inviting me to tonight's webinar. My hope really today is to shed some more light on the role of the Board Eligibility and Application Review Committee and discuss the eligibility criteria of the board examination. So the Board Eligibility Committee is a standing committee of the AABIP. It's actually formed of 20 members, 4 of which are Board of Director members, and the other 16 are chosen from the general membership. So this committee is really charged with reviewing and vetting applications for initial board certifications, recertifications, or any type of certificates that the AABIP is offering or would be offering in the future. So for the initial certification, this usually applies to fellows who have trained at accredited IP fellowship programs and who wish to board certify. They send their applications through a portal that typically opens in September of every year, so soon enough that portal will be open for graduating fellows. The second type of board applications that we started receiving this year in our committee is for board recertification. As you all know, this is a new application that has started this year. And we're currently receiving application for those who initially certified in 2014, which is 10 years from now or more. This being said, there is an option for diplomats to recertify 1 year ahead of time if they wish to do so, and it falls better with their schedule. And then the third board application process is for the practice pathway. For those of you who remember, the initial practice pathway was opened about more than 10 years ago now, and it closed around December 2016. Based on concerns from some AABIP members who missed the initial opportunity or window to apply through the practice pathway, the certification committee over the past year has been discussing this at length and elected to reopen the practice pathway one more time, and this time also for 2 years only, so applicants can apply in 2023 and 2024. This pathway targets only a select group of practitioners with a significant involvement in IP practice and day-to-day clinical practice, whether it's research or procedures. And to maintain consistency, the eligibility criteria for this practice pathway are very similar and exactly the same as the eligibility criteria from the prior practice pathway that was closed in 2016. And that was meant to maintain consistency. And then last but not least, the Board Eligibility Committee receives applications for certificates, AABIP certificates. The current certificate is for a certificate of added qualification for advanced bronchoscopists. So how do you apply to a board exam or a CAQ exam? And currently of interest is the board exam for tonight's purposes. This is done through an online portal, and I've took a snapshot of the AABIP website. By clicking on the board exam and certification tab, it will take you to the 2023 IP board application tab. And when you click on it, it will open a new page with a list of menu and options to choose from. So for the current time, the portal is only open for recertification and for the practice pathway. So when you click on each and one of these tabs, it will take you to a dedicated page for that board application that summarizes the deadline for application, the dates of exam, and all the requirements and eligibility criteria for that specific exam. So in the next few slides, I will summarize some of those requirements, and we will start with the IP board recertification. The first, obviously, eligibility criteria is to have certified 10 or 9 years ago. And basic documents would include a state medical license that's unexpired, NACV. However, what's very particular to recertification is an attestation form that explains that the applicant is been engaged in IP procedures, a minimum of 100. Acceptable IP procedure could be a combination of plural or airway procedures. Those procedures have to have taken place in the past 2 years from the time of attestation. And since some practitioners have an airway procedure dominant practice versus plural procedure dominant practice, the eligibility criteria currently would require that at least 30% of the non-dominant practice is in that field. And then last but not least, applicants who are unable for some reason to provide proof for this 100 acceptable IP procedures. And I would give an example, those would be physicians who are currently in leadership positions such as chief of division, chairman, those who are working necessarily, for example, in industry or active research with funded research. They may not have that much of clinical time. So when the certification committee set criteria for recertification, an option was given to that particular group to show proof of 25 consecutive acceptable procedures within the field of IP. However, the difference is they have to be primary operator. They cannot be supervising a fellow, for example, and they have to show outcomes. I have to say the predominant application or category of applications we're receiving are actually in the first category of those who have conducted more than 100 procedures within the past 2 years. So what's considered an acceptable procedure? The certification committee chose procedures that are not really common to the general practice. So as you can probably see on this slide on the left-hand side in that column is that it includes actually all the therapeutic rigid bronchoscopy interventions. That includes, the actual navigation, intubation, but also it could be anything from thermal ablation interventions, cryo interventions, PDT, cryotherapy, etc. And it also involves advanced pleural procedures that were selected to be as the thoracoscopy and tunnel indwelling pleural catheter. Now, this does not mean that those who have a advanced bronchoscopy predominant practice that they won't be eligible. All it says is that for recertification, they have to demonstrate a minimum number of procedures within the therapeutic realm of bronchoscopy, which is 100 in the past 2 years. Of note, a procedure log is not necessary. We get that question a lot in our committee. Just an attestation letter from a supervising physician, could be the chief of division, the director of IP program locally, attesting that the applicant has been part of those 100 procedures, acceptable procedures. So for the practice pathway, the eligibility criteria are a little bit more elaborate. Obviously, in addition to medical school diploma, state medical license, pulmonary boards and fellowship, etc., one of the important documents is an attestation letter that says that at least a third of the time, or 33% or more of the time of that applicant's professional activity is in the field of IP. And if that person has changed practice from prior 2016, we would need a letter from the person supervising that physician prior to 2016 for the same type of attestation that the predominant IP practice, the predominant practice of that physician was in the field of IP. Now, in this situation, a procedure log is necessary, and it should cover only the past 2 years from the time of application, so all the way back to 2021. And the applicant has to meet the procedural requirement in at least 2 out of the 3 core categories. The 3 core categories are pleural disease, airway disease, and so therapeutic bronchoscopy and advanced diagnostic bronchoscopy. And we will go over that list in the table in the next slide. slide. But in addition to that, the applicant has to show proof of being a primary operator in at least 10 therapeutic cases. It doesn't have to be rigid bronchoscopy, it could be done through flexible bronchoscopy and an endotracheal tube, but as long as it shows an intervention that's considered to be therapeutic, like recanalization of the airway or thermal ablation. For those cases, typically the applicants would submit a case description, they would describe the outcomes, and they would describe the follow-up that they conducted during that case, as well as images. And then the last two requirements is showing proof of consultation experience within the field of IP. That's like inpatient, outpatient encounters and visits, such as lung nodules, screening. It could be something related to tracheal stenosis, follow-up after stent placement, etc. And at least demonstration also of involvement in multidisciplinary patient management conferences. So that would be something like a tumor board, local tumor board, or maybe a transplant selection committee, etc. So what are the numbers needed? Those are, by the way, all listed in that web page on the website. So once you click on the right tab, it will kind of get you to all this information that I'm sharing with you tonight. But for complex airway diseases, at least 100 procedures are needed in the past 2 years, 100 advanced bronchoscopy cases in 75 pleural diseases. It doesn't have to be all three. It has to be 2 out of those 3. So 2 out of those 3 core procedures. And then for the IP encounters, inpatient, outpatient encounters, a total of a minimum of 200 and at least 25 conferences attended in multidisciplinary meetings. So on to my last slide, I just wanted to include links to the online applications and remind everyone that the deadline to apply for both the IP board recertification and the practice pathway is actually coming up very soon. It's going to be on October 2nd. The testing date by Measure, which is our testing center that we contract with, has been set to December 2 to December 9, which is basically the first week of this coming December. If you guys noticed that December 2 and 9 actually happen to be Saturdays, and that was meant on purpose so that we offer the chance for applicants who are busy during the week to have a chance to test on a weekend. And as you can see, those are QR codes that will give you direct access to the application process. So for those who are interested, feel free to scan it, and we're happy to show it again. And it will send you directly to the application. One last word I want to say is that once approved, and the applicants will be notified by email and a letter, and their information will be sent to the testing center, and they'll be able to schedule their exams. We do provide test accommodations for those who need it, and we're very happy to try to facilitate that. And thank you very, very much. I guess I'm going to pass it on to Dr. Pastis next.
Thank you, Labib. Let me share my screen too. So I just have a few slides, and the reason for that is a lot of the questions kind of repeated in certain categories. So we wanted to just take a moment to answer some frequently asked questions, both from social media and from the questions that came in prior to this webinar. So the first one is, explain the difference in procedural eligibility for recertification compared to the original 2014 practice pathway. So I think this gets to the fact that a lot of people are still confusing the practice pathway from the recertification. I think Labib went through the differences. The practice pathway came about as a means to be inclusive. It came to the attention of the AABIP that there were, not a lot, but there were a small to moderate number of physicians that either missed the initial opportunity for the practice pathway, or perhaps didn't realize that they would need board certification. Maybe they were performing rigid bronchoscopy, pleuroscopy, but didn't anticipate that they may need to be part of a fellowship down the road as more fellowships took traction and caught on across the country. So the practice pathway was for that purpose. It's reopened in a time-limited way for 2 years, with the anticipation that the ABIM transition, if and when it occurs, will not likely have a practice pathway. They may, we can't say for sure, as Tim said, this is to give clarity, this is not certainty, but most likely when you have an ACGME accredited fellowship, they're less likely to offer a practice pathway. So it may give those folks an opportunity and those deserving individuals that missed the initial window. And again, it's procedure logs and attestations. It's also different from the recertification because we really couldn't change it in fairness to the original regulations of the practice pathway. And then recertification, we're at the 10-year mark from the first round in 2014. And this also includes a new era of accredited fellowships. So these requirements have to take those into account to be fair to those individuals in accredited fellowships. So they have a slightly different procedural requirements, as Labib went over. And this is no necessity for a procedure log. You can have an attestation unless you're in that select few that are in administrative research. Then there's a procedure log, but only 25 cases. So where did we get this 100 cases or 25 cases? We took it from interventional cardiology because there wasn't a great other precedent in pulmonary, and it seemed to be the most parallel opportunity to model, whereas GI does not have a similar board certification process for interventional GI. So it really was cardiology, and they were through the ABIM. So the question also comes about is what happens if I don't recertify? What if my board certification expires? Will I have to redo the test with ABIM? So we really can't say for sure, but it's highly recommended to go ahead and certify under the AABIP because it's possible that you could be stuck with no opportunity to get certified in ABIM if they don't offer a practice pathway. And then, so if you wait for that board to take over, you may not be allowed to sit for the exam. And they're most likely going to look at those that have an AABIP board certification that's active, or they're just graduates of a accredited fellowship. So the other thing is, as far as should I go ahead and recertify, we really don't know the timeline. However, it does take quite a few years. So if and when the ABIM takes over, it probably won't be for another couple of years by the time the application's accepted. And then it may take another 2 years for the American Board of Medical Specialties to accept that application. So it's not as if this is going to happen right away. So keep that in mind as you make that decision. Another question came about. Another good question is, we see that the AABIP board pass rates are quite high. So what's the value of that when it seems like almost anybody can pass it is the thought process. Well, Tim alluded to this as well. The board exam is not meant to represent excellence. It's meant to represent competence, where you can make the diagnosis, where you can take care of a patient, make the appropriate safe decisions related to a procedure, et cetera. Not necessarily to always show that you're the highest performer. So if you're a minimally competent physician and you've been through an accredited fellowship training program, it would not be unexpected to have a 90% pass rate. There's also the fact that there are added benefits to preparing for board examinations. There have been some surveys, both in internal medicine and in family practice, that showed that physicians that prepared for board examinations, internal medicine ones that prepared for ABIM, had an improved knowledge, or felt they had improved knowledge, ordered fewer tests, fewer unnecessary tests, and had greater confidence in educating patients and fellow physicians. And then there's the educational principle, where assessment actually leads to more preparation, more retention of knowledge. And then the last thing I'll mention is the fees, and I think Tim alluded to this. There is a cost for preparing these exams. The board of exam writers, exam validators do everything for free, voluntary, but the company that we deal with charges for exam validation, psychometrics, the science of testing questions. So if the really high performers most of them should get a question right. If most of them get it wrong, it's flagged for study. If there's the lower performers are getting a lot, they should get certain more difficult ones wrong. If they're getting them all right, there's cause to examine, to study. So these are what psychometricians do and help with developing a valid test. And we all want an exam of good quality. But that all being said, I think the AABIP recognizes the cost to physicians and are working hard to shave down some of the added costs where we can. More of this to follow. Those are the main questions that have come about, and I think I'll turn it over to the leads to bring up other questions if they're.
Wonderful. Thank you, everybody. This is Majid Shafiq, one of the co-hosts. Thank you, Tim, Lynn, Labib, Nick, for this excellent roundup. We all learned a ton. This is there's uncertainties galore, and I think you all did a great job not only highlighting what we know, but also what we don't know in the spirit of full transparency to help our membership take stock of this current transitory period, a very momentous period in the life of our subspecialty. I see that you all have been answering a lot of these questions that have been popping up in the Q&A section of Zoom. But I just wanted to go over one question, which I see that Labib, you have already sort of talked about, just to make sure that everybody has gotten to hear this, those who may not be able to sort of readily see the Q&A section. I think it's an important question that has come up quite frequently in social media as well. What about the folks that are getting certified recently in the year 2022 or this year or next year? Supposing this transition to ABIM goes through in the coming years, will those individuals have to retake an examination very soon? Could you elaborate on that a little more, please?
Did you want me to elaborate on this, Majid? Yes, sure.
Please.
So the first thing I wanted to mention is we're not sure when when that transition will take place. Is a little bit of uncertainty on this. So when we make plans for recertification, it is advisable to make plans independent of that transition. This being said, there's a lot of unknown around that transition itself, and the thought process is that when ABIM takes over board certification, they will have their own regulations that they will share with the IP community, and basically they will probably set their own maybe fees and regulations and eligibility, which at the present time is unknown. I think when the question came through, it was for recent fellows who've recertified in the past 3 years. We're hoping that by then, this would have become a little bit more clear, and we have achieved ABIM transitioning by that point in time. This being said, Dr. Tanu is here and maybe can shed a little bit more light on this as well. Thank you, Majid.
Thank you. I was going to ask Lynn next. Go ahead, please.
Sure. I think, is there precedent for what you all would be trying to do to become an ABIM subboard? And the only one I can think of is SLEEP. And when SLEEP wanted to become its own board because it had its own unique body of knowledge and skills, they, like you, I believe, had an exam, but it was an exam, produced by an outside company and not by ABIM, which obviously has its own high standards of assessment. So that I think the point that was made that recertification within AABIP, maintaining your certification in AABIP is likely going to be important in terms of the lack of a practice pathway because IP already has an accredited fellowship with ACGME. I hope that point is clear. And so I think that recertifying within AABIP will be important if you want to eventually be certified as an individual by an IP board within ABIM. Remember that, let's say you recertified in AABIP next year and that magically the ABIM subboard appears in 2 years. I think that's unlikely. But you don't have to take the boards at ABIM immediately. You may choose to, have whatever window that probably would be informed by people from this membership as to when do you have to take that ABIM examination to be certified. When you finish your pulmonary fellowship, you do not have to take the pulmonary boards the year you finish your fellowship. There's quite a bit of years in there, I forget what it is, it may be up to 7, that you are board eligible. And so that board eligibility, which applies only to the period after you finish your fellowship, lasts several years anyway. And so you don't have to recertify immediately with ABIM. If you choose to wait, it's fine. Does that make sense? I think there's this concept that the minute there's an exam at ABIM, I have to take it. And I don't think that's the case.
Thank you. I think that's a very important point you hit upon there. Lynn, if I could stay with you for another question too, real quick, in terms of precedents with the ABIM, could you shed some light on, are there situations, instances where the ABIM is the provider of certification, but not the test taker? Because this was discussed as one of the uncertainties that we may have going forward, whether ABIM. Yeah.
I'm sorry, the ABIM is the assessment agency, but what? But not.
So ABIM provides the certification, a subspecialty becomes ABIM certified, but ABIM does not take over the administration of that certifying examination. Is that a possibility?
No. I mean, ABIM is an assessment organization. That is fundamentally what all the boards are. That's why they exist. So they would never not be the assessor. And again, it's because they're applying their standard of rigor to the assessment, right? So the examination would, I think that would be an advantage for AABIP to pass along the task of assessment to an external agency. If you think of all our other societies, ATS, JUST, they are not the assessors, right? They are there, as Tim pointed out, for education, advocacy, research support. Their mission is really different than examination.
Wonderful. Thank you for clarifying that. And that's exactly what I had thought as well. We are at the top of the hour. I will be passing the baton on to Siwei momentarily to finish off with some closing announcements. But before that, I did want to give everybody else a moment, all the panelists, to see if there's anything additional that they wanted to highlight before we wrapped up.
I will start since I was the first to speak. I want to emphasize again, it's a voluntary process. IP board examination, just like CAQ, I see a question about CAQ there. Nobody's mandating anything. If you feel like that brings value to your practice, to your own ego, to your patients, if you believe in the assessment and the science of assessment for achieving competency and self-improvement, then take the test and certify and recertify. If you don't, if it doesn't matter, we're not here to judge. We're here to serve and to standardize that process. So please understand, we're striving for excellence, and that's through education and assessment. And ideally, that assessment should pass to a third body for credibility and sustainability. I thought I presented those arguments. Happy to continue to elaborate on this personally and the national arena. Thanks for having me tonight.
Nick, would love to hear any closing thoughts from you two. And by the way, would also love for you to take this latest question that just came at the top of the hour about the NB Pass as well, this alternative board certification option.
Yeah, that's an alternative pathway that's set up for people that do have to be ABIM certified, and it's a way to recertify. It's physician created and regulated. The problem with that is there's no guarantee that your hospital is going to accept it. It's not uniformly accepted as ABIM is. So there is a risk with taking that. It's not validated with the same rigor and science in terms of examination. So it does have that risk, but it is an option once you're ABIM certified.
Thank you very much. Lynn, if you had any additional closing thoughts, and by the way, I'd also love, in this very limited time we got left, if you had any thoughts on the impact of board certification on disparities. A very provocative question and a very thoughtful question that just came through in the Q&A section. And I'll code it for you. It says, quote, "Do you not worry that board certification will also increase disparities?"
So I assume that, I'll assume that that means related, for instance, to cost. And that ABIM and I think all the boards are quite aware that when people come out of fellowship, it may be a burden to pay the fees. And one thing is that we discussed this at our last board meeting, and the language about the fees and the fellowship timing is being cleaned up, because I think it's a little bit misleading about when you have to pay. So that's one thing. And the second thing is that if there is hardship to pay for that initial certification fee, you just reach out to ABIM. You know, somebody will also always answer the phone, and those things are things that can be taken into consideration, because we don't want there to be barriers to people being able to get their jobs and get certification and practice. So I hope that if there are barriers presented, particularly at that initial certification moment, that you would call us, because we absolutely want to help with that. I wanted to just comment on the alternate board. The requirement for that alternate board is that you hold an initial certification from an American board, in our case of internal medicine, but they are accepting people from other boards. They require a fee. They do not do an examination. So there's no assessment. It's really a fee, and you're given a certificate, and it's really based on the original certificate you got from your board, in our case, ABIM. And it really is the old lifetime certification. You never need to prove competence again. You do need to pay them some money for your certificate. And I think that they require CME, but again, I don't know how much documentation you have to present for that. As Nick pointed out, you know, you have a choice. You don't need to be certified at all. Often the determinants of whether you have to be certified are from your institution where you want to practice. And in some cases, if you want to participate with insurance carriers. And then just one last comment. I really respect AABIP for you all having done what you have done already. I'm quite impressed that from the get-go, you set out to set your own standards. I think that is really remarkable, and that you have kept this up to the point of now recertification. And again, you're holding a very high standard to make sure that people out there practicing are competent to do so. And I think you have the respect of your communities, I think, partly because that's very clear. And you've already gotten ACGME accreditation, which, you know, is a huge step. It will be a number of years just because you need more people actually for ABIM to create what would be by ABIM standards, a credible examination for that initial certification. But I think you've already really done a lot of the hard lift. So really good for you. It's very impressive.
Thank you so much, Lynn. I think, like Tim had mentioned, it comes from a place of empathy, and empathy is so crucial in all of this as well. It really is a testament to the wonderful hard work and vision of people like Tim and other people, some of the senior members of our community. Labib, we'll let you close off with final thoughts, and would also love for you to take this last remaining question
Sure, go
about
ahead.
whether the ABIM would honor a time period of 10 years or some other number. Or I would imagine you may not know the answer. You may
Yeah.
have forgotten your crystal ball at home today, but nonetheless, go right ahead.
I guess the short answer is, like I've already said, with ABIM, there's a lot of uncertainty, and that's actually a good question to be directed to ABIM. So the short answer is I do not know, but the likelihood that all board examinations have been, or all, I guess, most professional societies have been asking for recertification exam within 10 years. So I would imagine and think, and this is just my personal opinion, that it will be a 10-year recertification, but that remains unknown. This being said, I just want to say that it is my personal opinion that the decision to recertify for any board exam to me, is an altruistic personal decision. Has to do more with self-discipline, values and goals, and self-regulation. And it may not be for everyone, and depending on your field of practice, you may feel the need to do so or not. It doesn't affect necessarily whether you're credentialed to do procedures or not within your institutions. It doesn't necessarily attest to your competency, but it is a form of self-regulation, like Dr. Tanu has alluded to. And I see value in preparing for a board exam, relearning the things that I know, and maybe learning additional things that I potentially could have missed during my busy clinical days. And it's an opportunity for me to stay abreast with the latest knowledge. Yes, it could be costly. Yes, it comes with additional fees. Yes, it requires time for preparation. And I guess I would hope that we can work on try to decrease those costs. And I know that Dr. Passes has already alluded to this. We meet with the testing organizations and we try to see what can be done and where can we cut on costs, because we feel that, we have the same concerns that the general membership does have. But at the end of the day, and as much as I personally do not like it, I feel like my decision to recertify really relies on those values that I just have mentioned. So thank you, everyone.
Thank you so much once again. Siwe, please go ahead.
All right. Thank you all for taking time, of your evening today, and we're really grateful to have you spending your evening with us, sharing all this important information. I know it took a lot of time and effort to put things together, and also thank you everyone in the audience who took time to join us for the webinar and for all your questions. Hopefully, we have answered them to our best of abilities with what we know currently. We hope that you can join us for a future webinar as well. And if you're not a member of the ABIP yet, we always encourage you joining and take advantage of all the benefits. Thank you, and we will see you soon.